Good afternoon and welcome everyone to today's complimentary webinar on how Medicaid managed care organizations are addressing health equity presented by IAMHP and County Care. My name is Judith Ruiz Branch and I am the Director of External Affairs here at IAMHP, or the Illinois Association of Medicaid Health Plans for those who are not familiar. As a member organization for the Medicaid Managed Care Health Plans, IAMHP works with the Illinois state government, legislatures, advocacy groups, and Medicaid patients to invest in and provide high-quality health care focused on cost-effective, individualized care that helps the residents of Illinois live longer and healthier lives. But improving healthcare delivery systems is a never-ending job, and that is why we work closely with our members and our industry partners to achieve better health outcomes. As such, we are so excited to partner with one of our health plans, County Care, for today's presentation. But before we get started, I just want to run through some logistics. As you can see, IAMHP utilizes the GoToWebinar platform. So a GoToWebinar control panel should have popped up on the right-hand side of your computer screen if you are logged in via your computer. This is important to note because this is how you will be interacting with today's webinar. If at any point you have any questions or technical difficulties, please feel free to use the chat box or questions box to communicate directly with me. I am coming up as IAMHP admin or IAMHP organizer. Also note that we will be opening it up as always at the end for questions and answers. So you can either save your questions until then or put them in the questions box and we'll address them at the end. We will also be sending out a post-webinar email that will include materials from today's presentation. So before we jump in, I'd like to introduce our presenter for today, Dr. Yvonne Collins. Dr. Collins is a gynecologic oncologist and chief medical officer of County Care within Cook County Health Hospital Systems. She is a board certified in obstetrics, gynecology, and gynecologic oncology. Dr. Collins has devoted her career to educating underserved women on the importance of routine health maintenance. Her research interests includes community outreach and education on the causes, prevention, screening, and early detection of cervical cancer. She also has an interest in empowering women through education, eliminating barriers to care, and increasing access. She works within various communities and task force on developing ways to decrease racial disparities related to cervical cancer diagnoses, treatment, and mortality. She's provided health care here in the United States, as well as abroad in Central America, the Caribbean, Asia, and Africa. She lectures nationally and internationally with the goal being to educate on disease prevention and has been honored as an outstanding teacher and humanitarian of the year. So without further ado, I will turn it over to Dr. Collins.
Thank you very much, Judith. I'd like to take this opportunity to thank the entire IAMHP team. It's always a pleasure to do your lunch and learn sessions. So today we're talking about health equity, and we're going to look at it from the lens of what do we know about our health plan and our members. We'll discuss health equity related to our HFS quality pillars, examine the work around housing and security, and then lastly discuss efforts around other areas. I think we've all seen this definition of health equity. My apology. Of health equity, but what does it mean when we say health equity? It means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles. And what are those obstacles? So poverty, discrimination, and then everything that happens from those consequences. So powerlessness, lack of access to good jobs and fair pay, quality education, housing, safe environments, and healthcare. And some of those we are going to talk about today. I love this graphic because I think it depicts our population. So when we look at the far left of reality, we know that health and health equity and quality of care is not the same for all populations. And so when we look at this, that first graphic depicts it very clearly. We started talking about equality, so ensuring that everybody has everything. And we know that's not the answer either, because if you look from the graphic, yes, we give everybody a box, but for those who are shorter, they still can't see over the gate. We then move to equity. So, and with equity, we're learning that different populations need different things, whether it's related to healthcare, whether it's related to jobs, whether it's related to communication. But although we have given the shortest person in that equity depiction 2 boxes so that they're all equal height, we know there are still issues. And so really, I'd like for us to really look at how we get to liberation. That is, how do we move that barrier, and in this case, that fence, to improve the care for our Medicaid patients and members. I just put the graphic up here because we're going to talk a lot today about disproportionately impacted zip codes. And so when we look at those particular zip codes, we know that these are neighborhoods that are at 20% or worse of the poverty rate. 75% of children participate in the free lunch program. 20% of families receive SNAP benefits. And then unemployment rate can be as high as greater than 120% over the last 2 years. And so what does that equate to in terms of health and healthcare? Let's look a little bit at our health plan data. I think over the last 2 years, as we have lived in the pandemic called COVID, we have seen highlighted the disproportionate impact that this virus has had on populations of color. And so as the health plan, we monitor regularly what are our COVID vaccination rates for our population. And so you can see from the top 2 boxes, we are able to look at who's had at least 1 of 2 doses or 1 dose in the case of Johnson & Johnson versus who's fully vaccinated. And when we look at that data, we're probably at about 40%. But when we take it one step closer and we look at disproportionate impacted zip codes, we can see that there's still a lot of work to do in terms of those populations being fully vaccinated. I won't go through it today, but each of you should begin to look at what are your community partnerships? How can you better get into the communities of those that have not been vaccinated? What is it that's holding them back? Why are they hesitant? And those are questions I think we as a group have to answer in order to make an impact in that particular area. When we look at our membership related to those DIA zip codes, we thought it, I think, but we're pretty surprised to find that 80% of our membership lives within those zip codes. And what did that tell us? That told us that we're going to have to do it a little differently than we had in the past. Differently in terms of how we do outreach, differently in terms of how we engage, differently in terms of how we get our members to see their primary care providers. We then wanted to say, what do our populations look like in terms of key areas that we begin to look at? And we're going to focus really on 3 particular areas. So when we look at ED visits, we have began to look and dig deeper into our populations. And when we look at that, we know our highest ED utilizers in terms of communities are those on the eastern part of the county. When we take it a little further, we know that that includes Inglewood, that includes South Shore. There are also areas on the west side of Chicago where our membership is not as high, but we have a significantly high ED utilization. Again, that's 60644, which is the west side, Austin very commonly, 60624, which is Garfield Park, and 60651. And so as we begin to look at initiatives around steerage from the ED to the PCP's office, we know that these are areas that we need to focus on. We also know from this data that the south side of Chicago and our south suburbs also represent a majority of our population, and those are other areas of high opportunity. We then looked at inpatient admissions. What do we know about where our members are being admitted? Is it in their communities? Is it outside of their communities? Is there anything we need to do around our network? Again, we looked at our population, and again, not surprising, but higher rates of hospitalization, again, in that eastern part of the county, and our very highest inpatient admissions were in that particular area. And when we look at it, there were 10 zip codes that comprised over 100,000 of our members. And so when we began to look at initiatives around PCP engagement and ensuring that we have primary care providers in the neighborhoods where our members live, this piece of information becomes really, really helpful. Lastly, we looked at PCP visits. When you look at the graphic, you can see that it looks like we have PCP providers throughout our county. However, we know that, again, as I said earlier, the greatest opportunity for improvement is in our southern part of Cook County and in our southern suburbs. So when we talk about areas, if you're familiar with the area, again, Inglewood, Hyde Park, South Shore, those are areas where we know we have a lot of members, the graphic, 209,000, and we know that we don't have enough primary care providers in those areas. We also know that the highest number of PCP visits per eligible members are in those populations in the Northeast, which tend to be the more affluent areas, unlike some of the other disproportionate areas that we talked about. So as we take these 3 slides to begin to look at how we develop programming, we know that we can't respond to the Northeast portion of our county the same way that we're going to respond or implement or integrate into the western portion or the eastern portion of our community. And that becomes really, really important when we're looking at initiatives. We also wanted to look at, if we look at those same neighborhoods that we looked at in those last 3 slides, what do we know about utilization? We looked a little bit at ER and inpatient, but also we wanted to look at pharmacy spend. And what we've seen is that that doesn't necessarily equate, but is that an access issue? Is it because our members may not, in some of those disproportionate areas, not seeing their primary care physicians are as often? Is that why we're not spending as high a percentage of pharmacy spend on those members? So really another opportunity to say, are we allowing our Medicaid members the access that they need also around prescription drugs? So we learned a lot from that first piece of data. We then, as every health plan, was given an opportunity to have access to Metopio. And basically that's a data-driven tool that really provides information on where our members live. It takes, I think, almost 500 data points and allows you to have targeted planning. So we said, let's look at our disproportionately impacted zip codes in conjunction with some data from Metopio, and let's integrate that data to basically see what we can find. I won't read through all of these, but just some of the ones that I'm going to focus on today. If we look at that third line, food insecurity, the higher value means a higher proportion of members with food insecurity in that zip code. And for one of our zip codes, 60141, 41% of our members in that particular zip code were food insecure. So as we talk a little later about food programming, are there special programs that should be integrated into that community? When we look at deep poverty, again, the higher is the higher proportion of members affected. 18% of those that live in zip code 60612 live in severe poverty. And the one I have highlighted is the one that we're going to spend a little bit of time on today, because we're going to talk a little bit about housing, but rental assistance. And so when we look at rental assistance, just to help you interpret the values between 0 indicate a higher need for rental assistance, and values below 0 indicate less of a need for rental assistance. And we looked at our data for our members and where they live, and 60621 had the highest rental assistance index at 1.32. Remember I said above 0 is higher need, less than 0 is lower need. So that particular area has a substantial need for housing intervention because they're at high risk for rental assistance. And what does that equate to? Those are populations that will be at higher risk for potential eviction. These are communities that are less likely going to be housing secure. And so how do we begin to target members where we're able to identify, using just many tools, but just this one tool, to identify which risk factor they have and how we as a health plan can intervene? We then took this data one step further and said, how do we begin to integrate that into everything else we know about that particular zip code and area of specialty? So when we looked at it, there were 406,000 members in zip codes that had the highest quartile of rental assistance. 23% of those members lived in the top 10 zip codes. And for those top 10 zip codes, the average rental assistance index was 940%, 940% higher than the average. So not only can we identify what the need is, where the member is, and how much need they have. And so with that information, we then said, what do we know about all of those other factors that health plans tend to look at to determine health outcomes? So ED visits and PCP visits. And what we found, again, related to ED visits, the difference between those percentage groups we talked about was about 24%. And PCP visits was -5%. So that lets us know that, of course, we need to talk about housing, but in order for us to improve healthcare for that particular group of zip codes, we also have to talk about PCP engagement and how we get them into the office. Because ultimately, if we can get them into the PCP office, we get them hopefully out of the ED, we get better control of all of their chronic conditions, and hopefully decrease those inpatient admissions. So a lot of data here, really trying to figure out how you make this information actionable in terms of how you take care of members. And that's what we're working through currently as a health plan. We took that data that we just looked at and began to create our own health equity dashboard. We look at the Metopio data, we look at all of the zip codes, we look at our demographic and utilization data that we have. And basically we can use this information in any array of ways. We can look at it in terms of programming for us, but we can also look at it as we begin to build partnerships in helping communities assess or do a needs assessment of what their particular communities need. If you look at it, our dashboard, we're able to filter on any social determinant of health risk factor. We're also able to filter on our CMEs. So if we want to focus on one group over the other, we're able to determine, is it a disproportionately impacted zip code or not? And if we want to get into, and we should be getting into, sex and race, we're able to really dig deeper now into those communities, which gives us a lot of information in terms of how we should interact and what that programming should look like. Now, as we segue to the HFS pillars, just in case everybody is not aware, if we look on the left side of the screen, HFS has 5 pillars of impact. These are our quality measures, and on the left side are those measures that we are paid for based on how we perform. So they include adult behavioral health, follow-up after hospitalization, both 7-day and 30-day, follow-up after emergency visits, again, 7-day and 30-day, children's behavioral health. Again, are we following up our children after they're hospitalized for a mental illness, either in the ED or in the hospital? Pillar 3 is maternal and child health. So prenatal care and postnatal care, we know makes a difference for the pregnant mom. Is that prenatal care timely? And is that postpartum care timely? And also looking at childhood immunizations. Pillar 4 is what HFS has defined as the equity pillar. And why is that? Because these are diseases within this category where we know that ethnic minorities have been disproportionately affected. So on the pay for performance side, that's breast cancer screening, cervical cancer screening, controlling high blood pressure, and also included in there are access to preventative and ambulatory healthcare services. So are you seeing your PCP? And then pillar 5, although there are not any pay for performance measures, this is the program around how we get members that may be in skilled nursing facilities or in mental health facilities or group homes. How do we get that group of members back acclimated into the community? And so I won't go through all of the pay for reporting measures, but if we look at this graphic, these are all the initiatives that HFS has put forward for us to work on in terms of how we improve the outcomes for the members that we take care of. I'm going to do a little deeper dive into pillar 4, the equity pillar, and talk a little bit about some work we've done here at the health plan. So first of all, when we initially got the pillars, we knew that there was not one group that could get through all of the pillars. So we developed performance enhancement work, improvement work groups. What we did is we have co-chairs for each of those groups, and we also have an executive sponsor. And this group was responsible for identifying what the measure is, identifying what the research is around that measure, identifying what our metrics look like from the year before, and really beginning to create initiatives around each of these pillars. And so what we did as part of this group is we did equity training. And why is that important? Because in order for us to have an equity lens really on everything that we do as a health plan, everybody that works in the health plan has to understand the impact of, number one, what is a social determinant, but how they impact our members and subsequently the health outcomes that they have. Next, we wanted to ensure that once we sort of laid the groundwork, beginning to think beyond that individual and begin to look at the community. So if you go back to that zip code data, we now know how that entire community is affected, and we should be looking at that population with a deeper lens. And then stratification. Of course, we always want to be able to identify the racial, ethnicity, geographic, and age disparities that we see in our care. But then more importantly than identification is how can we begin to address them. And some of the work that you'll see in a few slides sort of looks at how we began to chip away at some of that with some smaller initiatives. What we also had each group do is really do a fishbone diagram exercise, because this focuses on breast cancer screening and why are all of our county care members not undergoing their screening. So if you think about it, we can think of any array of reasons as to why a member may not go in for a visit. Is it time? Is it appointment availability? Is it that they don't know? Is it a cultural factor? Is it COVID? Is it transportation? Is it that they have more important things to think about, like housing, that they don't want to think about their breast cancer screening right now? So we went through that entire exercise for all 5 of our groups so we could better understand what is the cause and effect associated with whichever factor we were going to look at. And so when we looked at breast cancer screening, we identified, yes, there are definitely social determinants that play a role, but there are also access issues that play a role and system issues. And so in order for us to talk about social determinants, we have to talk about access and we have to talk about systems in order for us to make an impact overall. And so that's what we try to do as we work through some of these exercises. So I'm going to tell you about 2 targeted outreach initiatives we did with 2 provider groups. The first provider group targeted outreach on 2 zip codes, 60619, which includes the communities there, but the ones I think that come to mind very commonly are Roseland and Calumet Heights. 60628, which also includes a portion of Calumet Heights and Roseland, but also Washington Heights. And really, when we look at both of these zip codes, these are disproportionately affected areas. We then identified where each of these, where this group fit in terms of each of those quality equity measures. So again, breast cancer screening, cervical cancer screening, controlling blood pressure, and again, PCP visits. And so what this group did, they identified the members within those 2 zip codes who had been seen but had not had their routine screening. And we broke it down into whether or not they had anywhere from 1 gap in care to 4 gaps in care. They began to make targeted outreach calls to those members. They provided assistance with scheduling any visit they needed, especially mammogram and PCP visits. And then they did a follow-up phone call after the appointment to ensure that the appointment had been completed. Just a little sidebar, in that box, you'll see one of the areas that we know is a concern that we are working on, again, as a health plan, is that very commonly, sometimes we don't have the correct numbers for members. And in this case, 15% of members we had no contact information for. But we outreached a total of 1,400 members, and we'll go through some of that data in just a moment. We did the same thing also for those that had 2 or more gaps in care, and went through that same process to begin to identify, can we schedule appointments and can we get them in? Members again express appreciation for having the option of transportation, although some of them didn't perceive it as a barrier, but the fact that we offered an outreach to them was important. And so when we look at this initiative, the goal was, could we move the bar on these 4 quality measures? The top bar is PCP visits, breast cancer screening, controlling blood pressure, and then cervical cancer screening. If you look at the far right, this is just some follow-up data that we have as of December. It shows how much movement we had. So if you think about 60619, when we started this initiative, they were at 44.6 for PCP visits. It went up to 53.4. Breast cancer screenings, 34.9 to 36.3. Blood pressure and controlling those rates, 1.5 to 6.5. And cervical cancer screening, 35.4 to 39.5. And so this is some of the reason why I titled the lecture Chipping Away, because we know these populations have drastically more needs in general. We know that it's going to be harder to get them in to close these gaps. So I would say that's success. We move the bar on every single one of these measures, really with targeted outreach. And it's really just an example of, this was just 2 zip codes, an example of what can be done on a larger scale as you begin to target your outreach to those communities and what they need. Provider group 2, we did the same thing. We gave them their baseline data. We identified where the opportunities were in terms of, where they had mammogram centers, where they had PCPs, and began to look at where could we do some community engagement. And so we settled on the fact that if we look at this graphic, the vast majority of those members in these zip codes that we focused on, 60609 for this initiative, 60615, 60621, 60637, and 60653, the vast majority of those members had only 1 gap to close. So what is it that we can do to move them to close that 1 gap? We focused on all 4, but just wanted to put in the graphic that really most of them only have 1 gap. And so sometimes if providers know what the deficit is in terms of those numbers, they can do a very strategic, focused initiative to try to close that gap. And that's what we attempted to help this provider group with. We had a health fair extravaganza at Providence Hospital in October. We gave the providers what members there were in that area, what deficits they had. We offered to schedule, and we as a health plan called those members individually and offered to schedule their mammograms, their pap smears, their PCP visits with a blood pressure check. And so what we found or what we thought would make a difference was that outreach. And so as we look at it, we also know that when we talk about successes for this particular initiative, we close gaps. There were members that said their health plan had never called them. So we improved our member engagement and interaction. Our volunteers were staff, both of our health plan and our health system. We worked through some of our initiatives around staff engagement. We increased the goal around disparity around these health equity areas and these particular zip codes. We promoted our health plan. And if you look at some of the member comments, which I think is the win-win also, they like being able to get all the services done at once. They had been waiting for services like a mammogram for months because of the pandemic, and then we called. They were glad that services were offered on a Saturday because it's hard to come in during the week. So not only did we have that member interaction, but I think we gained some information in terms of why members don't come in that we can use for other members and other initiatives. If we look at the right, again, small numbers, but chipping away, we closed 22 mammogram gaps, 14 pap smear gaps, 13 PCP gaps, and we vaccinated or offered vaccination to folks that perhaps had not gotten it, which I think is good. So these are just two scenarios of where we took the data that we had related to our HFS pillars, we took the data that we had related to our disproportionately impacted zip codes, and we created initiatives, again, ultimately to close gaps, but two different ways that we can do that, just as examples of what we're doing. As I sort of segue into the next part, as part of our annual report, we always want to look at what are the social factors that are identified for members, because that again gives us another piece of information is what we think important and what we see in the data, really what members would like for us to focus on. The top graphic are those adults 18 and older. The bottom graphic are our children 0 to 17. And both arrows show that number one was help with food, clothing, and shelter. For adults, a combined percentage of 10%, and of our children, a combined percentage of 12%. And again, only about a tenth of our population, but again, gives you some information. And so I'm going to talk a little bit through some of the initiatives we've done around these particular areas. So housing, we know, is multifaceted. We know that there are members that are housing unstable. They may go to a friend's house this day, to our aunt's house this day. We have members who live in shelters. And then we have those members that actually are literally homeless and live in the encampments that we very commonly see driving. And so County Care has decided that we want to be able to take care of the member along that entire path of what homelessness may look like. So what does that look like? So it looks like prevention. How do we begin to identify, based on some of that rental assistance data that we have, who's at risk for eviction, and then how do we prevent it or divert them from being evicted? Crisis, we have someone, we know that they are experiencing homelessness now. How do we bridge them? And is it either bridge housing or is it medical respite? And then how do we talk about housing in terms of permanent supportive housing, which is part of the flexible housing pool, or rapidly rehousing those that perhaps have been evicted so we don't lose them? And so when we look at the battle against homelessness, it includes all of those factors, but also it includes, when we can, allowing members and helping members identify income. So employment, because we know it helps with how you feel about yourself. It helps with you understanding the importance of housing. And so those components around how you get income is also important as we talk about this battle. And so those are some of the initiatives as we plan our strategy around homelessness that we're beginning to look at. Medical respite, just in case anybody is unaware, there are 136 programs in the US. We know what medical respite does. It decreases hospital lines. It decreases ER visits. It decreases subsequent inpatient visits. And we know that the return on investment for each hospital dollar that you invest in medical respite gives you back 81%. And so medical respite is very important to County Care. And so we funded respite during the pandemic at the Southside YMCA. And then with our reinvestment dollars, invested in the Medical Respite Center of Oak Park, which is run by the Cook County Health System. So medical respite is just one component, but a very important component of housing our members and ensuring that when they're the most vulnerable, they have somewhere to go, not necessarily shelter or the street. And if you haven't been to the Medical Respite Center, I would recommend you take a tour because it's really an impressive facility. And then the flexible housing pool. The other part of this is that we were strategic in terms of saying, we know that our members who experience homelessness, we have to do something about it. And again, as part of our reinvestment dollars, we invested in the flexible housing pool so that we could, although again, a small number chipping away, house 66 of our vulnerable members. And to date, 33 of those have been housed in the flexible housing pool. I'm proud also to say we've been a part of the Advancing Health Equity Learning Collaborative. And this collaborative is a collaborative where you bring together MCOs, you bring together the departments like HFS, you bring together federally qualified healthcare centers, and really the goal is to develop a payment innovation around any inequity there is. We chose housing. We were one of 7 teams. We finished I'm getting all of my years mixed up now with COVID, last fall, and now we're preparing for phase 2. But really the goal is, as we look at housing within the flexible housing pool, we know that tenancy supports and care coordination are very important for this group of members. And so we are exploring that tenancy support portion as an investment model for Medicaid, because if we can get payment for that, we know the difference that will make in terms of housing. And so let's talk about some of the other strategies. One of the other areas when we looked at our annual report was food insecurity. Again, if we take some of our top 10 zip codes, we can see where that zip code is, what part of the county it is, whether or not it's a disproportionately affected zip code, which it is, and then what's the food insecurity rate. And so you can see if we take the highest, again, 60621, 41% of that zip code is noted as being food insecure. Again, 1.9% of our population, but if you take all 10 of those zip codes and add them up, that's almost 80,000 members and 20% of our population. So food security is something that we have to absolutely address. We've addressed it previously in other partnerships. We've worked with the Greater Chicago Food Depository in terms of fresh food trucks at various clinics and providing fresh produce in our clinics. We have participated with the Black Oaks Fresh Food Market. Food is medicine, where providers can prescribe those healthy foods. You can double your link or SNAP benefits when you purchase them. We've also done initiatives around prepared meals with independent living solutions during COVID, but has continued. But if you look at those are very small initiatives. And so I say what's next in the context of we are looking at something on a grander scale as we look at population health and making impacts on communities of color, especially, but those that are disproportionately affected. Because we know food then translates into better control of your diabetes. It equates into better control of your blood pressure. It equates into you controlling obesity. And we know that if we can make strides in just those 3, we can make significant strides in terms of improving the health of our Medicaid members, but also the savings, which allows us to invest in other kinds of partnerships and initiatives for this particular population. Lastly, I want to talk about the justice involved population. We have the opportunity of now, as of April, having those members come directly to our health plan. And why is that important? Because if you look at those middle 2 circles, CERMAC Health Services, where these members are detained, are also a part of our health system. So we have already been providing them care. It just makes sense to continue that once they are released. And so as part of this program, they complete their Medicaid application and intake at intake. If they have not, we can then connect them to services so that when they then are ready for community reentry, we're able to link them to the health services that they needed, because we've already begun to identify some of those while they were detained. And just some graphics of why this is important. If we look at the incarceration statistics, 1 in 9 men are incarcerated, compared to, if you break it down based on race and ethnicity, that's 1 in 17 for white men, 1 in 3 for Black men, 1 in 6 for Latinx men. So I'm not going to get on my bandwagon today about mass incarceration, but solely from those numbers, if we're going to talk about health equity and do something about health equity, this is indeed in a population that we can focus on because we know this population goes in with a significant amount of behavioral health and substance use. We know those are the needs that they have. And so how do we begin to prepare for when they come out, how to provide those needs? The bottom graphic, I thought if you didn't believe it from the top graphic, just look at the ethnic breakdown of those that are incarcerated here in Illinois by race and ethnicity. 258 whites, 472 Hispanics, 821 American Indians and Alaskan Natives, and 2,128 Blacks. If we talk about disparities and how we chip away at it, this is definitely an area that we have to continue to work on and chip away at. So hopefully today I've given you a good sense of just a little bit of what County Care is doing around equity. We have put equity at the forefront of how we think and how we operate and how we move forward in the care of our members. And as I conclude some of our equity goals as we go forward, is we want to continue our equity training for our health plan staff. We want them to understand the importance of social determinants and how we impact them. We continue to increase our minority and women business enterprise spend because we know when we have contractors, vendors, others outside of the health plan that look like our membership, it makes a difference. We've hired an equity officer for the system. We are now looking at an equity officer specifically for the health plan. We're looking at health equity accreditation. That was the new name for the NCQA multicultural designation. So we're looking at what is the data needed for that accreditation, is that feasible for us, and how we then move forward with that accreditation. We continue to build our racial disparity dashboard, which I showed you a little earlier, and incorporating that with Copio data, which are so important in terms of learning about our populations in the sense of things that we may not know. We have a huge member demographics campaign because we think it's important that we know what is the age of our member, what is the ethnic makeup of our member, what is the language that our member speaks, so that we can begin to cater and create programming around those specific populations. And last but definitely not least, we're looking at what do incentives for providers look like around equity. So do we now reimburse or incentivize for providers that use Z codes, because that gives us a little bit more information about the population that they're taking care of? Do we give incentives for providers that are just in those DIA zip codes, taking care of our members in those zip codes? Do we begin to look at further incentives around those equity measures in terms of breast cancer screening, HIV and cervical cancer screening? Do we incentivize when you are able to identify that a member needs a resource and are able to tie them to that resource, however you decide to do it, but really beginning to look at how can we incentivize our providers for the work that they're doing in equity, because we know so many of them are doing it. So this is just some of the goals we've put forth over the next year. Some of it we've started working on this year, but this is just a glimpse into County Care and how we're hoping to move equity forward as we continue to talk about equity at the forefront of everything we do. So again, thank you to the IAMHP team for allowing me just to present a little bit on County Care today and our equity initiatives, and happy to take any questions.
Thank you so much, Dr. Collins. That was amazing. And yes, we have a few questions, so we will run through them. The first one is from Daniel. He's asking, does diabetes care fit into your health equity dashboard tracks?
So diabetes specifically does not, but I think as we talk about the integration of food insecurity into our dashboard, and we look at those populations where we know food insecurity can impact disease, I think that will definitely be one that's at the very top of the list. We know for sure that food insecurity affects not only what foods a member may eat, their access to the medications they take, how often they're checking their glucose, and the education they have around food. So not directly in the dashboard, but indirectly, absolutely, the impact that we can make on diabetes will definitely come up indirectly via the dashboard.
Thank you. Great. And along those same lines, benefits of housing, benefits of food, why they're so important to health plans, and kind of the initiatives that you guys are implementing.
Absolutely. I didn't show the data here, but Los Angeles and New York has done a really good job at showing what is that return on investment for health plans when you house members. And so we know that it makes a difference in those parameters that we're very often looking at as a health plan. So making a difference in terms of that member being engaged. So if we go back to our Advancing Health Equity Initiative, we house our member and then we wrap around everything they need. Part of that is your visit to your primary care provider, because we believe if you can get in to see that primary care provider and you are engaged with that primary care provider, you then are not in the ER, you then are not admitted, your blood pressure is better controlled, your diabetes is better controlled, you're taking your medications as prescribed. And both of those states have shown without a doubt that those are the benefits of housing that we have seen and we know make a difference on that investment in housing. As part of the flexible housing pool, the evaluation is currently underway to look at, are those the same statistics related to health outcomes that we are seeing within our housing program. And even further, as the health plan is part of our smaller initiative with Advancing Health Equity, we're trying to determine how best we can evaluate that, because the hope would be we would see those same goals, and that would be the benefit. For food, very similar. So the data has shown around 4 specific diseases. So diabetes, hypertension, hyperlipidemia, and obesity. Not only when you create food programming, and that's not just making food available to members, it's teaching them how to read labels. It's teaching them how to shop. It's teaching them how to get the healthiest but the most economical food when they're shopping. So you may not have access based on where you live to fresh fruits and vegetables. But we know because of the salt content in some cans, a frozen vegetable may be better for you, or frozen fruit, beginning to teach members that, but at a population sort of stance. So we can identify all of our diabetic patients. We can put them into our food program. We can have them meet with the dietitian, learn to read food labels, learn how to shop. And all of the data has shown that makes a difference, not only in how they engage with their provider, but also how they handle their disease. So they're more likely to check their glucose if they haven't been. They're more likely to exercise when they haven't been, because now they're empowered with so much of the knowledge that they hadn't had. And I say doing it on a bigger scale because I don't know that we have enough dietitians to see all of our members on a regular cadence. But if we're doing that virtually, we can probably get more of those members seen who haven't seen. So we know for those 4 diseases, food makes a significant impact. And that's what we're hoping to gain as we roll out our food insecurity programming.
That is such a great perspective and insight. And it just sounds like, community partnerships are really important to the plans when addressing health equity. And we could probably talk another hour about that. But we have a few more questions that I want to get to, and these are great questions. They're kind of across the board, so bear with me. But the next one is, how is County Care thinking about the maternity and racial disparities when it comes to maternal health that exists within that population? Will there be focused initiatives on mom and baby?
Absolutely. I didn't deep dive into that, but yes, there are definitely initiatives around mom and baby. I think we all know the astounding statistics around maternal mortality. For our Cook County area, we know that there are definitely zip codes and areas where there are no providers. So beginning to identify what are those zip codes that don't have providers, what kind of providers can we get within that area? So is it a physician? Is it a nurse practitioner? Is it a midwife? Is it a doula? How can we get those providers that may not be the sort of provider that you're used to seeing into communities to outreach to those communities. Also beginning to look at, we know for mom and baby, the time that they get in makes a difference. So that pillar becomes really important at how we identify when our members become pregnant and how quickly we get them in to see the provider. So do we incentivize for getting you in quicker? Lots of discussion around that. And also the important part of that provider that's taking care of mom. We know if we look at some of the more high profile cases, we know that those are educated women who knew exactly what was going on with their bodies, yet they're still ignored and developed untoward sequelae from being pregnant. So how do we teach sensitivity and cultural competency overall to our providers that are taking care of our members? And so we're starting also to work with March of Dimes to do exactly that. How do we ensure that the message that we want as a health plan to our providers is out there? And so when we think about it, as I sort of answer the question in summary, it is really the importance of care and access to care. It's the importance of quality care and our members being heard. And the last part of it is long-term care. Care can't just stop at that 6-week visit. We know that there are complications that come at 3 months, 6 months. We know that depression is significantly high at that 9 to 12 months. So really looking at that entire peripartum period and beginning to focus on that. So just a little bit of what we're doing. I would say mom and baby are absolutely as important as breast cancer and cervical cancer.
Thank you. And along the same lines, another question was, are there any plans for metrics or targeted efforts around contraceptive care and reproductive/sexual health?
So yes, there is. I'm just trying to figure out how much I can say about it because it hasn't completely rolled out. Let me answer the question this way. We believe that reproductive and sexual health from adolescence to death is very important. We believe that empowering patients around making decisions of what's best for them in terms of contraception is very important. We also know that a lot of our members have not had that experience. And so the initiative that we hopefully will be rolling out soon is exactly that. It's an engagement, educational opportunity for members to just have a discussion. You know, how do you plan for pregnancy when you have so many other factors against you? You know, so how do we begin to have those conversations? So we're starting to look at that from the perspective of the entire gamut of age groups. So yes, it's not directly in our equity plan per se because it hasn't rolled out. It's really just in development now, but definitely we are looking at that because that is important. When we talk about sexual justice or injustice, we know that this is a population that is not counseled or prescribed contraception at levels of other populations. So yes, it's definitely indeed an issue we have to address and are planning to address.
Awesome, thank you. Excuse me, Amber is asking, what are your thoughts on opportunities associated with alternative payment methodologies, also known as APMs, as an avenue to improve quality and outcomes and addressing health disparities?
I'll preface this by I'm a medical officer. I don't dabble in finance at all, but I will say those I think anytime you're talking about looking at an health outcome and wanting to measure it, those alternative payment models become really, really important. So I don't think it will be any different in this realm as we talk about equity as it has been in any other realm that we've talked about as a health plan.
Okay. And someone wants to know, which I was thinking the same thing, but is there a potential opportunity for us, I guess they mean their organization, or yeah, health organizations and community partners to use your model slash initiative to certify staff and organizations in health equity as well?
So our training program is really homegrown. It was sort of developed by our staff internally. I would say absolutely. I think the more important item is if you are in a larger institution, there are now some programming around health equity that you can purchase, and there are trainers that can come on site to train. There are various avenues. Happy to share whatever we have and what we've done. But there are definitely a wide vast of organizations that can help you with that. March of Dimes, although it focuses on mom and baby, they have really done a great job at looking at equity from different perspectives. So that would be another avenue that I would say if you haven't been on their website to look at their programming, you may want to look at that. But sure, happy to share.
Thank you so much. And then the last question, in terms of when you were going over specific bookings like mammograms, they were asking, are they at pre-specific or pre-arranged sites when County Care outreaches the member?
So yes, as part of the health extravaganza, we worked with one facility. So when we called members and we scheduled, we sent them to those facilities. The other initiative, they identified a series of facilities so that they could give members an option depending upon where they wanted to go. So either is fine, but yes, the goal is to already have identified a partner that you know has capacity so that as you're scheduling members, access and capacity is not an issue because you want to eliminate that barrier.
Yeah, and to that end, in our last 3 minutes, I just wanted to circle back to the importance of community partnerships for health plans, and especially when you talk about the various initiatives. Can you just highlight that a little bit?
Sure. So if you look at any area that was discussed today, it's a huge mountain of patients, members, community members that we have to impact. County Care can't do it alone. MCOs even can't do it alone. We need all of our community partners working with us, especially those community partners that are already in those zip codes working. And so I do this as a call to all of our community partners potentially that are on the phone. Reach out to us and we'll reach out to you. But in order for us to continue to move the needle on any of the social determinants, we have to do it together. The adage of it takes a village is definitely it takes a village to get rid of health inequities and healthcare disparities. So we need you to help us in the fight to better take care of our members.
Thank you so much. That's such a great note to end on, Dr. Collins, and I can't thank you enough and County Care Health Plan for joining us today, this afternoon. The hour flew by because this is just such, oh my goodness, important information, and I hope that every attendee just walks away with so much more knowledge. Again, we will be following up with a post-webinar email and materials will be provided. If you guys have any questions, please feel free to respond to that email and reach out to IAMHP. We're happy to connect you. If you have any additional questions for Dr. Collins, we're happy to take those as well via email. But thank you so much for joining us this afternoon, and we hope you enjoy the rest of your day. Thank you so much.
Thank you very much. Always a pleasure.